Okay, hi everyone. I shared the agenda for what we were going to discuss today, but I'll briefly run through it so people who haven't had a chance to look through the slide will know what we are planning to cover today. So I wanted to just introduce and welcome everyone. We're not going to go around and introduce everybody. We'll be here forever. So if people are asking a question, please do introduce yourself. In terms of the show and tell, we are going to cover mainly the dashboard side of the work that happens within the London Analytics platform, because London Analytics platform has got a multitude of use case. We have the proactive use case where clinicians interact with dashboards, and then we have the research use case where people will interact with the back end. So today we are going to focus more on the proactive use case, which is dashboard side, and we are planning to, demo two dashboards. The first one, CBD action, and the second one is the mental health with physical health checks. We are going to focus on the dashboard in the next session as well for people to know. And we will be covering a couple more dashboards in the next session as well. So all of you get a good idea about, the principle and how we work through these dashboards. So that's the idea. In terms of the show and tell sessions that we have had so far, lots of people keep asking me. So I wanted to clarify that before we get into the actual dashboard show and tell. We have created a YouTube channel and we have saved all of the LAP show and tell recordings within the YouTube channel. So I've put it here. So if you click on this link that I have shared on my screen, you can get to the YouTube and we will continue to upload all of the recordings, within 2-3 days after we have done the show and tell. So Dean, I know, for example, Sean can't join the Monday one because of clinical duty. So please do share this widely with other stakeholders who would benefit from this. On that note, let me move on to show and tell and welcome Matt Kearney. Matt, thank you so much for joining today. So Matt is the clinical lead for the CBD Action Dashboard and have invited him to join today so he can describe the purpose of CBD Action Dashboard, how we started on this journey, what has been the engagement routes, and what is it that we are trying to achieve. So shall I pass on to you, Matt?
Yeah, lovely. Thanks, Kavit, and thanks so much for inviting me today. I think we've got some slides between us we're going to share. Thank you. So yeah, I'm Matt Kearney, I'm a GP and senior advisor at UCL Partners. I was also the previous National Clinical Director for CVD Prevention. So I led development of the long-term plan for CVD prevention and founded CVD Prevent, which is the national audit, and 96% of practice in England now take part of that. And what we're talking about today and the fantastic collaboration we've had with Kavita and her team over the last year or so is on how we make data actionable in primary care. And I know that's a challenge for all of us. We know that data is very important, but we know it doesn't always drive change that we hope for. Just as the background to this, it was critical to me in my national clinical director work that we moved on from just iterating that there's a problem in getting stuff done in primary care to understanding why that is and unpicking and defining the challenge that is CVD prevention. So we know it's huge and it accounts for a lot of healthcare, social resource utilisation. It's a big driver of health inequalities. Recent data from the Tony Blair Institute shows that if we reduced CVD incidents by 20%, we'd add £2.2 billion to the economy. And of course, the government is very interested in this link between what we're doing in the clinical world and the wider economy. We know you can prevent heart attacks and strokes through lifestyle change, but also by using the high impact treatments in these conditions here, blood pressure, cholesterol, CKD, diabetes, etc. And the next slide, please. What we know though about, oh, sorry, was there, could we just go back one? Oh, no, sorry, that is correct. That is correct. I'm sorry, forgetting my own slides. Yes, move on to the next one. Thank you. But we know from size of the prize that there's significant underuse of these high impact treatments. So for London, currently, 1/3 of people with hypertension are treated to target. Size of the prize shows what's been happening to that over the last 3 or 4 years since before COVID. it shows the huge dip in performance 1 year into COVID, as we saw with all of our long-term conditions. But what you can see is that 4 years on, we're still not back to the pre-COVID position. If you look at the in-year variation graph just below, though, it shows that actually each March we do hit a peak, but then immediately afterwards it drops off and we don't recover in performance until the following March, because we as GPs, we manage our QOF targets, then we move on to the other multiple priorities that we have. What we did with Size of the Prize was to set levels of ambition. So if we reach sort of 74 or 77 or 80% optimization rates, how many heart attacks and strokes would we prevent? And you can see from the blue box on the right there that if we got to 80% in London, it would prevent 2,200 heart attacks and strokes in 3 years, 17,000 across the country. So these are huge numbers in terms of impact on patients and population health. If we look at cholesterol management in people with CVD, we see the same sort of under treatment, but huge potential. Next slide, please. So what we know about these conditions, oh yeah, that's just to highlight variation. This is every practice in London, data from last March, blood pressure optimization rates. There's a 40% variation in how we do in individual practices, and much of that will be unwarranted variation. Next slide, please. And so just looking now at these boxes at the bottom, many people do not receive the NICE recommended high impact treatments. There's wide variation, but we know it's not just because GPs are not reading the guidance, it's actually because this simple stuff is hard to do in general practice in the real world, where time pressure, multimorbidity, complexity is the norm. So this is very much a wicked problem. Despite having wonderful data tools, QOF and NICE and CQC and all those other drivers, we've seen very little improvement in blood pressure management and the management of these other high-risk conditions over a number of decades, and it's because it's hard to do. But on the other hand, if we could increase uptake just to reasonable levels of ambition in these high-impact treatments, we would prevent thousands of heart attacks and strokes. So that was our starting point with CVD Action. The next slide, please. With the challenge that how do we enable primary care to make better use of data, but in the real world where they have no time or capacity, so that they can deliver not just a marginal change, but a step change in the management of these conditions to prevent heart attacks and strokes at scale, because the evidence makes it very clear we will. So CVD Action has been developed mainly by London clinicians with a clinical led by UCL Partners, and I chaired the work, but with a team of GPs and other clinicians from across London ICBs. It's been designed to bridge the gap between data and action in primary care by doing some very specific things. First of all, it reflects CVD Prevent, so it covers the same indicators as in CVD Prevent in the 6 conditions on the right, but there's more granularity. It doesn't try to do everything. It focuses on the high impact treatments, and it focuses on capacity. So there are about 85 indicators integrated into simple dashboards, and Kavita will show that in a moment, but data can be examined at practice PCN or system level. We built for EMIS and System 1 with an SQL build also. If you look at CVD Prevent, the national audit, it will tell you you're not doing very well in, say, CKD management, but it doesn't tell me as a GP who the patients are. I have to go away, build searches, run them, bring the patients in. CVD Action identifies the patients, but not in big splurges of this is work I've got to do, actually very much in manageable chunks that fits capacity, that allows me to safely prioritize, decide where to start, phase my work over time. It also brings in multimorbidity, so we can manage multiple risk factors at one time. And importantly, it also provides a health inequalities filter that you can run at practice or ICB level. So you could find all your patients across an ICB with poorly managed hypertension who also have severe mental illness, or who also belong to the most deprived group or a specific ethnic group. So you can target health inequalities in that way. Next slide, please. So this is the list of GPs and other clinicians. Neville Purcell was from Northwest London, others from around London, particularly in the UCLP patch. Next slide, please. So just the last 2 slides I'm going to show. We have lots of data available to us, but it's often not actionable. In Northwest London, through Kavita's team's work, we now have CVD Action for the whole population. if you look on the left here, the key high impact treatments, there are 4 of them. If you want to prevent heart attacks and strokes in your population, you focus on blood pressure optimization, lipid lowering therapy, renal angiotensin antagonists, and SGLT2s. These are the big ones that drive all the improvement. If we click on one slide, please, this shows the numbers in northwest London of patients. So we've got 96,000 patients wandering around with hypertension not treated to target, of whom 3,500 have a blood pressure above 180. I mean, that's really dangerously high. 21,000 people with CVD who are not on any lipid-lowering therapy, which should be, bog standard first-line therapy. And many people will have heart attacks and strokes because they're not on those treatments. So this gives us insight now at population level into the numbers not on those treatments. So I'll hand over to Kavita now.
Thanks, Matt. So what I'm going to do is share the actual dashboard so you can see, the metrics that currently gets covered within the dashboard. So what I'm sharing is a demo version. So this is not real data. But this is purely for training sessions and show and tell sessions. So this is what the CVD Action dashboard will look like. As Matt said, we are looking at the CVD patients and these 6 areas that pertain to their care: hypertension, atrial fibrillation, cholesterol, CKD, diabetes, as well as non-diabetic hyperglycemia. So it is basically giving us, the ability to see all of the information in the same page rather than having to go into 6 dashboards, which is probably what we as BI teams would do. We'll have a hypertension dashboard and a separate dashboard for AF, separate for cholesterol, etc. So it gives us in a single place all of these key metrics. So the steering group that Matt described came up with all of these metrics that needs to be captured within the CVD Action that we should focus our attention on and focus our primary care colleagues to really, drive the right treatments for these patients. So within hypertension, you have a range of metrics like that. Within each of these, you have a range of metrics and the value is recorded. And this is based on, running the search in the backend data, the primary care data that we currently hold. So the intention is, as we receive data from London Data Service, we'll have the primary care data for the whole of London, and we can apply these searches once for the whole of London and be able to track these numbers for all of the general practices across London. If you want to go into the individual area, you click on these tabs and you get into each one of those areas in a bit more detail. I will let that come up in a second. So this is just the hypertension, and within hypertension, you start to look at the blood pressure monitoring and able to see who are those who have, blood pressures between 160 to 179, and those with over 180. There is also age restriction that is applied. So we know, that for under 80s, we look at 150 over 160 and 150 over 160, whereas with over 80s we look at a higher blood pressure. So all of these metrics are basically pulled straight from primary care and presented here. The other benefit of this is if you want to focus in on, say, all your blood pressures over 180 over 20, you click on this bar, which is, just those BP over 180. And then at the bottom, you can click on the show patients. So this will actually show you who those patients are that fall under that criteria. And the benefit of this is it, gives the practices a case finding ability to work on those patients that they need to do something about. Either, send them a text message and, bring them in for blood pressure checking, or, direct them to the local pharmacy if that is, the approach, etc. Because there's a demo tool, we are not, displaying the patient level data, so you can't see it, but that's the functionality that you will see. Equally, if you want to look at the demographics, back to what Matt said about tracking health inequalities, is there inequalities that exist within that particular metrics, you can start to zone down by age and ethnicity or deprivation and start to look at, is there any variation between ethnic groups, or is there any massive variation between age or gender that we should focus our attention on. So that's really a principle of, how the dashboard is designed. And finally, it is really clear that we can't just, send a dashboard out to practices and, expect them to start using it without any help or support. So you have this help panel right here. So we have, what clinical actions they need to undertake, basically a tutorial video about, how they should use this dashboard, and, show them how to navigate the dashboard and between the different screens, and, also the definitions of all of these indicators that's presented here. So everything is like in the same place. So if people want to click on each of this, they can, get into those areas and start to look at it. So I'll just click on one of it so you can see. But see, this is the action that they have to undertake. And, it talks about, because I was on the hypertension and I clicked on it, it starts to say what are the actions that, the clinicians will need to undertake. So all of these has been carefully developed with, clinical engagement across the region. So that's really what I wanted to, say for the moment. And I will come back to, how we can make this dashboard available for you to start to interrogate it and look at it at your own time, because I appreciate we take 15, 20 minutes to cover this. So one of the things, I am planning to do, and we have, within our team, have put all of these dashboards into a demo site, and we will be sharing the link with all of you at the end of this session, so you can take it away and look at all of the metrics and think about, are these the right metrics? Is this what you would like to focus on? Is there any feedback on the metrics as such, or is there any feedback around the look and feel and how the dashboard is visualized? So that's what we want to capture, but I will reiterate that towards the end of the session. But I will stop there and see if anybody has any questions. Dean.
Thanks, Kavitha. They are really good, and I think we've got a really good set of resources to try and leverage, haven't we? One of the questions I'd got, given my experience around things like Cerner Healthy Intent, for example, is some of the tools or the sort of what were they called? Registries that Cerner have developed, which is kind of similar in principle to these, have a way of kind of going from whole population down into, for example, a subset of the population, like a geographical subset of the population, which might be place, and then from there into a number of practices within the place, or a number of PCNs within the place, and then practices, and you kind of keep going down then into your clinical indicators and into your identifiable patient list, and therefore the dashboard becomes multifunctional in the users that it can service, in that it could be suitable for service management, it could be suitable for planners to use, or it could be used by people delivering the care on the ground. Do your tools work in that way? Can they work in that way, or is that something that we can build into the development pipeline?
Yes, absolutely. That is how we work. We start with the full population, and then we say, what is the, percentage of population? So start tracking the prevalence, and then, look at filtering, or, drilling down into place level, PCN level, practice level. So it goes back to the question that Jack has put in the chat. So that is a standardized design that we have adopted within the LAP. But CBD action is a bit of an outlier because, we did have some other developers working on it. So through this cycle of establishing this as part of the London Analytics platform, we will have to confine to similar design principles. So that is our approach. So as we go through the next dashboard, Dean, you will find that that is a sort of principle we are applying.
Because I think that, I mean, not that I won't labor it too much. I think that's just really important for us to be able to kind of go big, scale down, bring ourselves down to that group of people that we want to action, because it then supports all the commissioning, all the incentive, all the other bits of component enabling parts that we need to make this work. Great, thank you.
Thanks, Dean. Jack?
He's telling me you put it in for the wrong day.
Sorry.
We're here tomorrow, aren't we?
It's not me.
Someone needs to go on mute, I think.
Okay. It's great, Kavitha. Thank you. I mean, it would be so good to get this stuff off the ground. I mean, one of my queries is about the way we represent inequalities, and if we can get a standardized way of doing that across London. I say this slightly, and it may be just a completely personal prejudice. I look at the ones that our ICB does, Saviour's on the call, and I do get them now, but they weren't represented in a way that I was used to. And I just wondered if we need to get some sort of way of agreeing what is the appropriate way to represent these things, whether it's a user interface or an epidemiological truth that I'm getting at. I'm not quite sure, but it would be quite good to agree how we should represent these things, because we're going to do it time and time and time again, aren't we, across these dashboards?
Yeah. Agreed, Jack. So what we are, going to be discussing initially is the standard look and feel. But you're right, we have to have some agreement about how we represent health inequalities. So one of the things that, I am looking at is establishing a user group. Like how LDS have established a user group for the BI to look at, detailed conversations about what data needs to come in, what logic and rules needs to apply. We need to have a user group, because show and tell, we are just about like saying what we are doing at a high level, and we don't have time to go through it. So a user group will be established in the new year in January. And that is where we can start to, have a real concise discussion where we will have like a couple of reps from each ICS and start to think about how it should be presented and, bring back a recommendation to the show and tell. So that is the idea. Great. Matt, do you want to come in and
Yes,
maybe give the
you.
closing sort of view?
Yeah. Thanks very much, and thanks for the comments, and all really important. I think it's important to stress that one of the things we've been trying to do with CVD Action is to do something different for clinicians on the ground. So this will give you data at multiple levels. Yes, you can look at the population. To be honest, we're awash with information for population levels, and some of it's great and some of it's not so great. I'm sure we all understand that. There's a gap between all the wonderful information and what we as clinicians do in our routine consultations. And there's often, I think we all rely on the magic to happen in clinical consultations, that we've got the data, we know the problem, we will do something about it. The reality that doesn't happen, and what the specific design principles about CVD Action focus on the end user in clinical practice, particularly trying to turn this wonderful data into something that will influence practice in the day-to-day on the ground. So as we move forward for CVD Action, those design principles are also of critical importance. It'll be how we best integrate those, I think, with wider platforms. Just the final thing to mention is that data is just one part of the story. Clinical data is essential, but CVD Action is a programme that brings in wider implementation support, and the London-wide demonstrator programme covering 10 PCNs at the moment includes a lot of information and transformation support, because we know the data itself will not drive the action. So as we move forward with CVD Action to London more widely, we'll be looking at, so how do we put in place the implementation support that all sites will need to translate the data into action. So thank you, Kavita. Thanks very much for inviting me today. Thank you.
Thanks, Matt. That was super helpful. So we are planning to share all the slides that we'll be using today. I didn't want to share it, out cold without you getting, any views from us. So that's why we'll be sharing after the session. So that's CVD Action. Rachel, shall we move on to the next dashboard about the mental health?
Yeah, that's fine. Thank you, Kavita. I'm just going to share my screen. Okay, so hi everybody. For those who haven't met me before, I'm Rachel McCarthy. I'm the Business Analytics and Deployment Lead. So today I'm going to be showing you through the mental health dashboards. So there's two particular dashboards I want to show you in this area. They are going to be available on this demo site that you'll be able to have a look at. So please do take time afterwards, once we've shared that link, to go and have a look and see what you think and provide some feedback to us. But to take you through this, I've just got a couple of pieces I wanted to start with to explain how we get to a dashboard in the first place. And this is the general principle for the process that I'm showing on my screen. Very first thing that is really key to any dashboard development is understanding the use case, the need for the information that's going to be displayed. So really understanding the purpose, the user stories, and get that initial understanding of what the suggested metrics need to be. And this then will really drive the next step, which is workshops with those stakeholders. So we need to identify who the stakeholders will be from our clinical and our programs, so within our ICBs and our clinical leads across all the different areas, who are our stakeholders, and make sure that we get their voices heard at the early stages before the development even begins. And this is really to ensure that whatever comes out the other end is going to be useful and it can actually make a difference. So we're not just going to create a pretty dashboard because it looks great and for people who are interested in data, but actually it can be used by those different user groups for those different user stories and then provide a difference at the end. So how do we ensure that what we hear from our stakeholders in these workshops actually develops into something that can be user friendly and can be understood by all? So we don't really want to waste too much time by just building, reviewing, building, reviewing, building, reviewing. So what we like to do is go through a step creating wireframes. This is quite a quick and simple way to create what the visualizations for all of these metrics that we've discussed and agreed will look like before actually putting the additional effort into building the dashboards out. So there's no time lost during this phase because developers can certainly start work on the back end data side of things, but actually the visualization point where we want to ensure there is good usability through these dashboards can be done fairly quickly and without too much time required by creating wireframes. And I'm going to show that we have an example wireframe here. So you can see here, it's not very neat, like it's not like a dashboard where it's really crisp and clean. And that's because it's pulled together to give an indication as to what each of those metrics would look like in a dashboard. What sort of options would the user have in all the different drop downs? How will it look? And this allows us to very quickly get some feedback on the look and feel and bring that then back to the drawing board, to those stakeholders to discuss how we might want to change this before developing a final version. When we understand how we want those wireframes to look, we then move into the building of the dashboard. And so this is done through the developers, takes some time to bring that together. But once that's together, the dashboard will then be in a user assurance testing phase. This is a really important phase before we get to the end dashboard, because this is where for a lot of the users will have a subset of testers who will get first chance to have a real go at the data, at the dashboard. How does it work? What will I learn from this? Does it interact with me the way I expect it to? And also this is the data validation checks as well. This is the first time we'll be actually seeing the data for real. Is that what we expected to see? Have we got all the calculations working the right way? So it's a really important phase before it becomes live to everybody. And then of course, then we've got our final version, our go live, which will be available via the Tableau website through the HSCN, so it's secure. But that is just very briefly a background to the process from the idea through to the actual end product. So the dashboard I want to show you here is the mental health radar first. This is, again, this is through our demo site, so no real data here. But I want to show you like how this one works. What does it show us? This is here showing all patients listed who you have access to with a mental health condition. And against each patient, we've got some key metrics. Okay, people at the top, we've got lots of red dots. People towards the bottom, we've got a few more green dots going on. So all of these metrics are RAG rated. Have they met a criteria? Have they met a threshold? in order to turn themselves green. Green being good, red being out of date, not done, not very good at all. Amber being that partly met criteria. So for each patient, we can see their physical health checks being completed in the last 12 months. So we've got BMI, blood pressure, pulse rhythm, Q risk, serum cholesterol levels. And then we move on to some social metrics, so alcohol, smoking, substance misuse, etc. And then following on to the care plan section, really looking at different types of care plans and documentation that is developed or completed during the year with the patients. And the purpose for this and seeing it in this way is for the out of hospital cohort. These are the set of criteria. This is the minimal data set criteria for each patient from the practice's point of view in order to see if they've met the criteria for those particular patients in the last 12 months. So anybody who's got a load of red on here, that means they haven't met the criteria for anything, any of these metrics so far. But as we scroll down, we get to see those who have got a few more greens there or ambers where they may have been partly met their metric required. So this is all in relation to that criteria requirement by practice. From here, there's a few things that can be done on the dashboard, and this is where we will see some standardization, some across the different dashboards that you will be able to see in the demo site. There's some similarities in each of the dashboards, and this all relates to these top filters that we have here. So we can filter by health borough. So if there's access to more than one borough, you've got the option to choose by that. You can drill down and then select by primary care network or by practice. In this case, I've selected 2 practices out of all the ones I've got access to. We've also got age band, deprivation, ethnicity, and then patient segments. So these are some standard filters that we'll see. And I'm going to take us on to a population health dashboard in a moment where you'll see these same filters applied again. The additional filters, the more sort of specific to the dashboard filters, comes further down on the page. So you get the standardized ones at the top, then the more specific filters further down. In this case, this dashboard is defaulted to the out of hospital patients, but the cohort can be changed to include all mental health patients, those being seen by secondary care or other services. And within the out of hospital cohort, again, that can be split down even further into SMI and the complex common mental illnesses as well. So there's plenty of filters in order to chop that or slice that cohort even further. And then finally, we've got the sort functionality on the right-hand side. So it's defaulted to the number of metrics met in ascending order. But this could be changed to age or name, or we can change it to descending and see the patients at the top who've got all the greens. So very dynamic dashboard that can be driven through these filters. And that in whistle-stop tour fashion, that's how this dashboard works. One additional step to this dashboard is from here, we may wish to see the details of one of the patients in more and a bit more history to these metrics. So there is a way to filter through to go to that patient summary. I've already got one up that's really nicely populated, seeing this is demo site. So I'm going to show you this one. So by clicking on the hyperlink, it takes you through to an individual patient summary based on those metrics that we've just been looking at and some additional information. So again, demo site being that we don't have some of this populated at the top, but we can see here through those different physical health checks what the latest information is, but we can also see along the graphs how that may have changed over time as well. Okay, so each one of those provides a little point in time and it shows us how that has changed over time. We've got lifestyle interventions. So first of all, what the lifestyle indicator is. So for example, alcohol status, are they a drinker? Yes, in this case they are, but there's no intervention implemented. Smoking status, ex-smoker, substance misuse, non-substance misuse, going there. And we've got drugs prescribed on the right-hand side. On the left-hand side, we've got all the blood tests and the latest results for all the blood tests. So for this one patient, it's quite a neat way to then drill down further into that detail for the patient and the history on some of those metrics so we can see the change over time. I'm going to now just close this and I'm going to show you the population health dashboard. So looking relatively...
And just as Rachel is bringing it up, just to be really clear, there is two versions of, a cohort. One version is what you just saw, where, you bring a cohort, you see the patient level information and why it is for the purpose of a multidisciplinary team to come together and, say, right, we know these are the patients. How could we, potentially slice and dice that and, bring to a sizable cohort that we can, think about intervention. That's really practically how it is being used in Northwest London today. Then you have the second dashboard, which is giving a more population health view. And again, going back to Jack, your point, we have a standard design principle where we have these, quadrant approach. When we do our population health dashboards, we always look at the, 4 quadrants: population quadrant, clinical, lifestyle, and finance. And then through each of it, you will have, the ability to view health, the inequality metrics as you go along, because we are building it up from patient level information. So we have 2 variations of the same thing, but they are all using the same data and the same logic, which means a source of truth is carried over to the stakeholders, whether you're a clinician or a commissioner or a borough-based partnership person or a PCN clinical director. Rachel, shall I bring Dean in before you get going?
Oh, yes,
Dean.
please.
It's okay, Rachel. You finish. I'll come in when you finished, if that's okay.
Are you sure? Okay.
Yeah, of course.
Thank you. Okay, so yes, as Kavita said, we've got a standardization on the population health dashboards where we've got 4 quadrants: population, clinical, finance, and lifestyle change, sometimes known as wider determinants. And in each of these areas, for population, it does this very high level look at some key metrics, such as the total population. I'll just point out again, this is demo, so made up numbers here again. Then the number of patients meeting the criteria for this this long-term condition, and some information around prevalence and so on. And then within clinical, more clinically driven metrics, which will of course change across the different LTCs. Financial, depending on the requirements, again, who's going to be using this and what financial information is required will determine the metrics in here. And lifestyle change, where we get a lot of information around smoking and other wider determinants, BMI, alcohol consumption, etc., would be seen in the lifestyle change area. For each of these quadrants, we can drill down further, and this is then when we get to see the different levels between borough, PCN, practice, INTs, etc. So I'm going to drill into population overview to show you how this looks. So as we saw earlier, we've got these same filters at the top here. We can see our KPIs first of all, and then a split by borough and a split by practice. And then the next set of graphs underneath, driven by the clinical requirements, includes those some of these metrics that we might see across different dashboards. And that's so that we can see alongside, if we want to know of our out of hospital mental health patients in who do smoke and maybe also have hypertension. We start to select those criteria, and then we can see how our population starts to change across all those different areas. So we'll take antipsychotics or lithium drugs being prescribed as well, and all that information starts to change. So it becomes very dynamic in a slightly different fashion to how we showed you with the patient radar with all the RAG rating dots previously.
Yeah. So the total population remains static, but as Rachel is clicking on the different tiles, the mental health patient count keeps changing. The 1599 that keeps changing. So if Rachel removes the antipsychotics, that would increase, and if she removes the hypertension, it will increase further. So that is how people get into a segment of a population that they want to focus on for a population health managed intervention. Yeah, Rachel.
So if I want to then drill down and say, I just want to be interested in one of the boroughs, we'll take Brent as the example. Again, you can do this from the health borough filter at the top. As you can see now, this just changes that and it shows us the entire population for Brent. If I want to then also look at from the age band point of view, ethnicity or deprivation, the same principle applies. The filters work, they will then apply it to the information below. We have here now the total population shows that 260,000 because we've just selected Brent, but the mental health patient population is smaller overall. Once looking at this dashboard and using some of the graphs to filter down the population to a smaller cohort that we may be interested in, for those with access to the patient identifiable, you can also then drill down further to view the patient list. Okay, so this is then the patient list, which it gives you who met that criteria and then the latest figures for each of those outcomes.
And that click to see patient list will be, managed through roles-based access, which we described in the last show and tell. So if a person who's accessing this dashboard is a clinician, which is the role that Rachel has taken for the demo, she can see the click here to view patient list. But if I'm, ICB person, I won't even see that, bit there. If Rachel points to that click here to view patient list, that won't even be visible to me. So I don't even have the ability to get there. I can only see the high level number. So that's how we know the roles-based access works, just to bring to life what we described over the slides last time.
Thank you. And just for completeness, I will briefly show you through the two other dashboards in this. So we've got the clinical overview. Again, look and feel quite similar as before, just a different set of metrics that we can see here. And then the final one is the lifestyle overview. And again, same look and feel. But what we get to see here is, again, some additional metrics, including the assessments that we showed on the first page as well. Again, apologies, this is our demo environment, so we do have a few little hiccups going on here, but something that we'll try to work out as quickly as possible.
Yeah, but the idea is that you have high level numbers on all of those metrics at the top, because, it's been suppressed, the numbers have been suppressed and, scattered. Something has happened there. As Rachel says, we can look up populating it whilst you review it. Thanks, Rachel. Let me bring in Jean and then Amy. Thank
you, Rachel. That was really good, and that isn't a wow. That's really good. Surprised that you've managed to do that. It is very good. As I was going through that, when you initially said we've kind of got a patient level 1 and a population level 1, I was concerned at that point, which is why I initially put my hand up, mainly because of what I was saying earlier on about being able to start at a population level and kind of work your way down then through the various levels of our integrated care systems and interested parties and users, so that we're all focusing on, as you said earlier, Kavitha, that kind of single version of the data so that we're all rowing in the same direction. When you then showed there were two things then. When you then showed that through the population one, you can still get to a registry of patients, great. One of the things that, again, and I only use this as example because of my experience, one of the things that Cerner do, even a step on from creating a list of patients, is when you get to that list of patients that you showed sort of in your population view, you can then click the patient and it almost takes you back to your previous dashboard where you can see the patient and all of the metrics that you showed on your previous dashboard. So, you know, by patient, you could see the physical bits and the social bits and the whatever else. And also, if those patients fall into other registry categories or other dashboard categories, it does the same thing again. So you'd go through your population dashboard, down to your registry of patient list, as you showed. You could then click on the person, it would bring up the other view that you showed earlier on, and then say, by the way, they're also on the CPD register, COPD register, they're on the asthma register, on the so-and-so register. So you almost have complete flexibility of moving through. Now, I'm sure some of this stuff's incredibly complicated to build, but it was just one of those things that having seen it, I just wonder whether that might be something that either
it's a really good point, Dean. And actually, it's something that we've done on other dashboards. So I've just shown, actually, I didn't mention it here because I was thinking about the time I had, but from that patient list, you can get through to the patient chart. It looks the same. So you can do that from both the radar and from the patient list. So, and it takes you through to the same dashboard. However, as you say, the bit about being on other registers, that's something that we have included on other dashboards that have, as it has been requested, and it's certainly something that is possible. I think very much when we're looking at these dashboards, and that initial step that I showed in my PowerPoint about what is the purpose and what do we want to pull together, sometimes these things don't always come up, and I think that's where the feedback from this group's really useful to say, actually, that would be a really good standard to have in all of the dashboards.
Yes,
you know,
agree.
that's where we would like to hear
It
that.
kind of it makes one of those, again, the design principles bit Jack was talking about earlier on. If we agree that and we apply it then to everything we build as a kind of design principle, even though the content might be different in each tool that we build, we get that consistency, that consistent look and feel and navigation and everything else. Anyway, I'll stop there. That's really helpful. Thank you ever so much.
Yeah, so basically that goes all the way from population to, like, you know, the place, the PCN, the practice, an actual patient, you know, goes all the way down. So absolutely that. Totally get your point about, you know, what are the metrics we can include, and that's the feedback we are looking for. Amy?
Thanks, Kavita. This is really, really helpful to see. So thank you. A couple of questions about functionality at PCN level. One is whether it's, and apologies if I missed it, it's possible to compare practices across a PCN. Because that sort of view operationally is often really, really helpful. And secondly, whether some of the R's roles, so people who are working across a PCN, can generate a PCN level list, so that, you know, if you've got a pharmacist or whatever, they can work at that level. So just those two questions, please.
Yes. So for the first one, yes, as Rachel is showing you, click on a PCN, and then within that PCN, you can see what is the number of mental health patients on that right where, you know, Rachel is pointing her mouse. You can see the variation by practice. And again, Amy, this is the thing, like, you know, if people want it shown slightly differently, we would like that feedback, but that's how it is being done at the moment. So you can see the variation between practice. In terms of the users, a PCN user can, you know, gain access to this and see it at an aggregate level. If they need access to patient level information, then, you know, they should have already got the IG squared off with the member practices to ensure that they can see patient level data. But if they have that and they prove that, you know, they have the IG, we give them, you know, the ability to go into the patient level list that Rachel showed. So that is the idea.
They could make a combined list from across.
Yeah. So if you go here, so this is Rachel has selected one PCN. If she goes on the click here to view patient list, it will give all of the patients that belong to that PCN.
Yeah.
So they get that combined list of all of the practice.
Okay. So subject to the IG in place, the functionality is there in order to support it. And yeah, I think there are things that might be helpful to do with the way in which
Yeah.
that kind of multi-practice view is presented for PCNs, but it's great to know that the basic functionality is there and we can just refine how it looks. Great,
Yeah.
thanks.
Jack?
I'm sorry to go back over ground. I wasn't at the last meeting. So I do like this. Thank you very much. My concern is maintenance of a register of some sort of users, and where you've got to in thinking about APIs from frontline systems so that you could pass role and whether someone was a clinician, etc. For instance, from EMIS into this system, so you don't need to keep a register of users. That's not how you're operating at the moment, is it?
No, so we keep a registry of users at the moment, that's because those clinicians who have the ability to see patient level information needs to be signed off by the Codica Guardian. So there is a process and that we go through, and what we are working through is automating that process. You make a valid point about like getting an API, but the problem is this is an integrated care system. It's not just general practice users who access it, it's acute, mental health, community, there's social care. So you need API with multiple EPRs to pull that data. And that is why we have not, sort of thought about it, but it's definitely worth considering if, there is a way to minimize the burden on maintaining that user register.
Yeah. I mean, I would think the Caldecott Gardens would say, look, if this person's a GP, they are entitled to see any personal data in relation to someone in their practice. I don't think that could be a general rule, couldn't it?
Yeah.
What sort of, so do all your GPs register to see it or not? Because we've got to lower the threshold, haven't we, for accessing this stuff?
Yeah, all our GPs are registered to see it, but the point I'm making, Jack, is it's more than GPs within a general care general practice setting. There are other people like nurses and even clinical coordinators. There's all sorts of hours roles that Amy mentioned, right? That's coming up, and we don't know how they are structured within general practice and PCN because they are different. There is no consistency. And that's why, we still are working through this process carefully because we have the responsibility to maintain the confidentiality of patient level information.
Absolutely.
Yeah. Thank you, Rachel. That's super helpful. Conscious of time, so I'm going to move on. Thank you. I knew, we will be up on time if we did the 2 dashboards. So what I wanted to say, and Ibi, maybe you can share the link, share your screen and show the demo page. Thanks, Ibi. So what we have created is we have created a page here, which we are calling the lab demo. And if Ibi clicks on the lab demo, we have listed all of the dashboards that, we originally sent around to say these are potential dashboards that we can make available at a London level. And how we came up with this list is basically the data used within these dashboards is that, coming to us via LDS. If it is, then yes, we can basically roll it up to London. So we have, created this site. You don't have to log in or anything. You just, click on the link. Ibi will put the link, of the URL in the chat now, but I will also send it around when I send all the slides. You can click on the link. You can get to the individual dashboards. And if you can review it within your ICS as a group and come back with, feedback, that'll be super helpful. In terms of providing feedback, we are offering 2 ways for you to provide feedback. One is to email the LAP mailbox, which I think Rachel has put in the chat. And also there is a feedback form that, Rachel will bring up on the screen. Rachel, if you can bring it up on the screen now to show people. You can also fill up the feedback form. So either, you can have like a free flow and send us an email of all your thoughts, or if you want to have a structured form to complete, then, we have created this, sort of online form for you to provide the feedback as well as you work through the dashboards. So because we have covered these 2 dashboards now, I thought, if you could prioritize reviewing these 2 dashboards within your groups to give the feedback, that will, give us some idea about what you'd like to see and will get us into as a sort of consistency with the design principles. That is my plan.
So just a quick one. Does it work just on NHS.net account recognition? Because ours might have a problem if we've got a local set of accounts. So should we log a call to see if we can get that sorted out?
For
Uh,
this demo site, you just need to be on HSCN.
Yeah, you don't need to be
If
NHS
it's
.net.
okay.
not working, then
Okay.
drop us an email and we
It
might
might be-
need to
Okay.
chat to IT
IT.
just about firewalls or IP addresses, or I don't know, the stuff that I don't really understand.
That's fine. We'll check it out because I don't know whether it shouldn't be because I'm tunneled in, but it could be because I'm working at home perhaps. But let's check it out. Let's see.
Yeah. Yeah, if there is a problem, just, send a screenshot of the error message, Dean, because I don't know whether it's related to NHS.net at all, but I can't think why it should be.
It
But we'll
won't be
pick it up with IT.
NHS.net. I think if anything, it might just be something that we have to ask your IT department just to whitelist the URL so you can get through. It might be your firewall side of
No
things.
problem. No probs. And Jack just popped a question in. I know I'm asking Jack's question for him, but Jack put a question in. One of the things we've been asked is about physical health checks for people with serious mental health problems. I think there was a section, wasn't there, called physical health or something in your initial dashboard. Kavitha, I've asked you the question before whether the things that were asked for were covered, and I think you said yes. Is that correct?
Yes.
Okay.
So the dashboard that Rachel said, covers all of the physical health checks that, SMI patients have to go through, and the sort of monitoring that we do as a standard target.
Cool.
Those are all of the, physical health checks that Rachel had on the screen when she showed the dashboard.
And there's a serious mental illness filter because it wasn't obvious that
Yes,
that was
there
serious
is.
mental illness.
There is.
Yeah,
Sorry,
thank you very
Jen,
much.
yeah.
Thank you.
Amy?
So can you get the composite view that says SMI health check done for, and a kind of variation chart, for example, within a practice or between a PCN, between practices between a PCN or PCNs at borough level to say how it's looking in terms of delivery of that outcome?
Yes.
Because that sort of stuff is so great, Kavitha.
Yes.
It's so
Yes.
great.
Yeah, so that's exactly, what we do for our own ICS. We give practice by practice, what is your total number of patients? What is the percentage of, patients that have had their physical check done? And we do it monthly so they can keep monitoring. And what
Yeah.
we then allow them to have is access to this dashboard so they know which patients they have to target to increase their, sort of performance up. So it's sort of lined up with our performance monitoring.
Love that.
Brilliant. Thank you all for your time today. If there is no further question, I will leave it at that. We finished 1 minute earlier. I thought we might be running out of time, but I will share all the slides we used and I will send through, the email ID, the feedback form, everything. So you have it as a single email from us. Because I
Awesome.
appreciate we have put in the chat, but it'll be easier if you send us a single email. I'll do that later today.
That was really good. Thank you ever so much.
Thank you. So next
Thank you.
time, a few more dashboards. So please join next month. Thank you.
Great stuff. See ya.
Thank you.
Take
Bye-bye.
care. Bye.